Testing 1 2 1 2. Check. Testing 1 2 1 2. Check. Testing 1 2 1 2. Check. Check 1 2. Check 1 2. Check 1 2. Testing 1 2 3 4 5 6 7. One, two, three, four, five. Hey, Matthias, would you mind going to the podium so I can just test out the volume?
Hello, can you hear me? Is this okay? Should I just keep talking and you tell me when it's okay? Hello, can you hear me? Hello, can you hear me now? Okay, should I just keep talking?
You're good.
Okay, good.
Yeah, you're good. Perfect. Thank you.
Okay.
Hey, Chief, would you mind going up there and just testing out your volume on the podium?
Somebody talking, right?
No, you're hearing things. Nobody's talking.
No.
That's your own head.
No,
Hey,
he
Chief,
said
would you
that.
mind
Look.
going up there and just testing out your volume on
Oh,
the
okay.
podium?
Test, test, test. Test, test, test.
Okay, that's good for 1 second. Hold on, let me just see.
Okay.
Yep, sounds good.
Test, test, test.
Yep, you're good. Thanks.
Okay, sounds good. Hey, Dr. Quick, how's everything? We're just testing the volume. Guess he said everything was okay.
Marshall will come in a second. He has a couple of up.
Simon, is it, so, I'm gonna drop, so Kelly's slides, she went over to, I'm just gonna paste them. Okay, take out the old one. So it shouldn't change anything. All right. You did a sound check and everything? It was okay? Okay. Oh no, that's not good. It opened right up before. Oops.
Everything cool?
Yeah, I think, okay, yeah, there we go. I'm just gonna copy these. And then paste them. Oh, hold on. How do I keep the source formatting? Oh, insert.
Testing 1 2 1 2.
No, oh boy. It's easier on my computer to keep the source formatting. Now I just messed it up.
Yeah, you want to like paste it, and when it says paste, then it's where actually in home. So when you do the go to home tab
So go to
for the to keep the source formatting.
go to home.
Yeah, so you see where it says paste.
Okay.
Oh wait, hold on.
Oh, whoops. I need to click on the arrow, right?
I realized I got like.
There it is. There it is, yeah.
Okay. So I think I can delete these two. One, two, three, 4, 5. 1, 2, 3, 4, 5. Let me see if that's how many it was. One, 2, 3, 4, 5. Yep, that's what it ends on. Okay. I don't know what we did. Okay. So maybe, I don't know the best position for the microphone. Should I not move it?
Marshall, I gotta tell you this really quickly because there's a lot of things going on. So, and just so happens, 2 o'clock, at the Lieberman wants me to record him.
Oh, okay.
So I am going to, so what's happening is this. You're on that computer right there where you were using,
Yeah.
there is no WebEx going to be needed. Forget about that. Why? Because my MCAS, which I normally use to
Yeah.
record a stream out to YouTube, is going to be, that computer will be using WebEx.
Okay.
And for the sharing my screen, I'm going to be sharing the streamed YouTube video. So while it's being streamed to YouTube, it's also going to be shown on on the WebEx.
Okay. So,
So you'll have 2 in 1. So if it all goes well, all I have to do is just stop the session.
okay.
And once YouTube has processed it, I can edit and chop out the beginning parts and leave it up there, and I'll give you the link.
So will the session start at 2 o'clock exactly, or how's it? Where's it gonna?
Yeah, so he wants to be done at so like 2:15. So I'm going to start you guys here at like maybe 1:50. I'll just start recording, and as soon as you pop up there, so it'll be full recording all this time, but nobody has that link to over there. So out like 10 minutes to know that when you come up to the podium, you are live.
Okay.
You're
All right.
going to be live.
As soon as I get, yeah.
You will be live.
Well, as soon as I get up to the
Yeah.
podium.
When
Okay.
you start coming
So
in-
will the recording still have that empty space in the beginning then, or are we?
Oh, no matter what, I'm gonna chop it up.
Okay.
Before we can put it out for everyone else to see.
Okay.
We'll do the editing regardless.
Okay.
It just is, it's better to, if I can have it already up on YouTube,
Yeah.
and then just do a quick little chop at the beginning.
And then,
And
okay.
then you'll have the rest of it there.
Okay.
I don't think you'll be, you guys will be probably here for about an hour and a half, 2 hours almost.
Yeah.
So, yeah, he won't be recording that long, so I will definitely be able to get it in before
Okay.
the end, and so there won't be any extra at the end.
Okay. All right.
It'll just be in the beginning, and it'll be hopefully about just 10 minutes worth.
10 minutes worth in the beginning. Okay. All right. Thanks.
Yep, so I'll be back a little, what are we going to Perfect. All right. Holy crap.
Hey, how's it going? I'm just kind of reviewing my slides and thinking about what I'm going to say. So, Kelly added some slides and she'll be going over those, and then these are mine. And some of these I just got very recently, so one of them I made this morning off of the PDF that was sent from Goer on gender identity. So I should really kind of look at that. And then there was another one that I was like, whoa, where did that come from? Yeah. I can actually mask up now since I'm not talking, but I guess when we talk, we're going to unmask. But I put hand sanitizer and wipes here for whoever feels better about doing it that way.
Yeah, that's a good question. Do we talk with the masks on or off?
Off. Once we get up. I mean, I was considering like windscreens, like for each of us, and I looked at them up on Amazon, but I didn't get a chance to order them. So I don't know. What time is it?
It's 1:40.
1:40. Simon, I guess let me know whenever you're going to start it, and then I'll leave the main slide on, because I was just reviewing my slides, but.
So what is the slide? I'm sorry.
Yeah. I'm just.
Okay, no problem.
Are you going to start? So I guess that's it. We'll just leave it up like this. Yeah. You know, I find that if I hold the clicker, then I'm more likely to move around. If I use the computer to advance the slides, I stay put.
Yeah,
So I think I'm gonna-
That's exactly what I did, because I found, and plus, I don't really click for some time.
Yeah.
You get a little hit of yourself. It's just a lot
Yeah.
easier.
Yeah, the chief likes to, he just holds it, but he stays still, and he just clicks through like this. But yeah, I guess I'm gonna have to, I think this keeps me stationary if I'm here.
I'm not used to downtime. I'm used to working.
Every minute, yeah, I know.
You know, it's like.
I have like 30 emails in my inbox, and I haven't been able to get to them.
Yeah.
And some of them were pretty important, but I can't, and so I feel bad that I'm just sitting here waiting, but I can't really. If I go and start doing that, I won't be here. Yeah. I know how I am.
Yeah. So how long have you been here, Marshall?
I have been here since 2012, so what is that?
8 years?
Yeah.
All right.
Yeah, so.
And the whole time the same office?
Well, I was actually in the Bronx for a little bit, and then I came here after that. So I don't know if it was 13 when I started here, or yeah, it was probably right then.
Well, what about you? Oh, you're talking to an old guy. How far back you want to go, right?
Well, how long have you been with the state? How many years?
Yeah, so I've got maybe 25 years now.
Yeah.
But that's because I worked with the state for 14 years, and I went to Europe for 10 years,
Oh, okay.
and then came back.
Okay.
So I have seen all my.
Hello. Are you Cecile?
I am.
Alicia, I'm the infectious consultant. Nice to meet
Alicia,
you.
it's very nice to meet you.
I think so. I'm gonna introduce you. Okay.
All right.
It's
Testing 1, 2.
Cecil Elmore, right?
Cecil?
Cecil.
Yeah, yeah.
Right.
I've always gone by Cecil because I'm named after my father. Growing up, it was all Big Cecil, Little Cecil. They got Cecil.
Ah.
And then after what, so Cecil? Yeah, so Cecil Elmore.
We could do it here instead of the computer, if we want to.
We're limited to 10 people in a room, but I don't know, like, yeah, if it's other.
I
We
mean,
can't have like more than one or two staff, I guess, because we're having 1, 2, 3, 4, 5 presenters, right? It's gonna be, but we're not all gonna be in here at the same time. So, but we
I could
can't-
share the computer with the other sergeant, right?
Yeah, whatever. I
So
mean,
you don't have to
if
be
it's
in a-
easier for you to sit in back, but just don't tell anyone because we can't have more than, once it gets over 10 people, we're breaking the rules. And there
But I don't
those are
have to
like
have an
central office
individual,
rules.
I don't have to be on the individual login, right? We could log into one computer and both watch.
The way we're giving credit is login, that's right.
Login,
You're
yeah.
right. But if you told us that you did it with somebody else and watched someone, we would add you in if you started. Or send us an email probably saying, I watched with such and such, and then that would be enough, because we just have to have some sort of proof that the date that we put on the spreadsheet,
Okay.
that goes to all the meetings, was.
So it's gonna be what, about half an hour, 45 minutes?
Yeah. So yeah, I would just send an, because most of the people we're gonna do, by their WebEx login. But if you wanna send it, if you watch with somebody else and send an email saying you watched with that person, we could use that email as.
Oh, okay, but mostly everyone, they have computers, right, around there? Are you expecting people to sit there?
No, we're expecting people to watch on WebEx.
Oh, you just have it here just in case?
Yeah, the only reason that we're doing it here is just because it's easier for the presenters. Yeah.
Marshall, what are you doing for environmental services and?
The chief's gonna go over it a little bit.
So you know what, I might come back at 2 o'clock. It's just that I don't wanna be confined to that office, that's why.
Yeah, it might be more space, but yeah, like I said, don't tell anybody else.
Yeah,
because-
I thought, or we could record it and just run it in here with 10 people.
Yeah,
at a
that's what we're
time.
doing, yeah, later on, we're gonna record it, so we're recording it today, and then later on, like, environmental services, other people can watch it in small groups,
Oh,
and,
okay.
and on recorded, but it has to be under 10, and that's including the presenter. So if one person is in here running the thing, then they can have 9 staff. Yeah.
So if I sit in a little corner, it'll be okay then, right?
Yeah, I mean, like I said, we have 5 presenters and Simon, and then we're not all gonna be in here.
And Simon's not very many.
Yeah, I don't.
And if
I
more
think
people
that-
come, I just kick them out.
Yeah, that's
Yeah,
right.
yeah, exactly.
I'll tell them, safety department, get out of here.
That's right. That sounds good.
All right.
Look at
I'll
all
be
the
back in a
changes.
Yeah, we'll have someone here to explain to them. It's only 10 people.
The good thing is it's once.
I'm sorry?
It's once.
Yeah, it's just
Not
once.
12 times.
And then, yeah, we can play the tape as many times as we want after that.
Well, I'm gonna take advantage of this time to get some of my new colleagues.
Yeah.
Because actually, it's been 7 months that I've part of this meeting.
Wow.
It's just,
You started right before, was it February or?
yeah, I came down in February for the interview,
Yeah.
and then, well, the rest is history, right?
Yeah,
Yeah.
yeah. And so, and your title is?
I am the assistant IT director, so Chris Hanley is the
IT director.
We're splitting his time between Albany and Manhattan.
So is he the IT director for all of OMH or?
No, not for
Make
all
sure
of
at
Old
least
Age.
6 feet
Oh,
apart.
yeah, sorry.
That's all right, thank you.
It's the first time I actually got out of my house.
Oh, really?
Oh,
Is
God.
Well,
this your
I
first
don't
time?
mean out of my house, I mean
Yeah.
for a work thing like
Yeah.
this.
So Chris has other responsibilities within OMH,
Yeah.
being the IT director for Nisby. And he was just, he was stretched thin, so
Okay.
that's how he was able to justify this position. So, when it is safe to come back to the environment, this is my workstation for the moment.
Right.
So, and actually, in another life, you asked me what I used to do. So I do go to Europe, but I also did spend time as an IT manager at Columbia University, and I lived there for years. So
Oh, you did?
Yeah, so this is
Okay.
like kind of coming home.
Oh, well, that was good choice then for them, right? Because you're familiar with the area and I don't know if the Columbia IT staff has probably all changed, but. Yeah.
It's quite a while ago.
So I managed to get your new slides in.
You know what I wanted to tell you, by the
Yeah.
way? So we had a pretty symbolic, on Veterans Day, there was a signing of a memorandum of understanding between New York State and our center, you know, and the Governor's Challenge, which says we're gonna model for the world how we're gonna make the Columbia part of everyday life for every New Yorker.
Yeah.
And so when New York State first sent everybody home, one of them said, you know, we need to give this to our workers, you know, to as a self-help check and a way to connect, et cetera. And then I went on CNN a few months into COVID and it was like a 6-minute piece, nice piece. And I said, you know, you might be lucky to get telehealth once a week, all the more important to have check in with your buddy and your friend and your neighbor. And AMA called me the next day and said, of course we know about the Columbia Protocol, but yes, how do we get it in every doctor's hands? So one of the things I'm gonna show is this little card with 2 doctors wearing masks and ask your fellow coworker. You know,
Yeah.
so it's really become part of the protecting the frontline workers narrative.
Yeah. I heard an interview with Dr. Lieberman and Chris Cuomo. He mentioned, Chris Cuomo mentioned you.
He did?
Yeah,
How
he
did I
did.
miss that?
It's on, so if you go on the COVID media stuff on our website, and it's like on the links of all the things, and it was one of the links, I forgot what the title of that link was, but I clicked on it, and it's a satellite radio interview.
On
Yeah.
Chris's
Yeah.
Chris's show.
Yeah, and Dr. Lieberman was on there, and he mentioned you.
Yeah, no, he's been one of the,
Yeah.
as you know, one of the biggest.
We got it live already.
Oh, we're live?
Yeah, live.
Okay.
I gotta go do a couple leaving now.
Okay, so we'll start it at 2 o'clock, and then you'll just edit it out.
Yeah.
But people can join.
They're already joining right now.
Oh, there are already people
Yeah,
joining?
like
Okay.
13 people already came.
Okay.
Were you hearing the beeps? They're like, boop,
No.
good.
No, we didn't.
Good,
Okay.
good.
On our end, so then, okay, so.
So do you wanna, you're
Oh,
gonna,
yeah,
Marshall, you're gonna introduce me?
but
Yes, I will.
barely. I can, if you're not in front of that mic. All right, Nick will do this for a second.
All right, thank you, Simon.
Yep.
Hi, Simon.
Hey, how you doing, Dr. Carver?
Hi, nice to meet you.
It's nice to meet you in person. This is a virtual experience.
I know, exactly. So you remember your tagline for the introduction?
Yes, I did. Don't worry, I practiced that part. That part I'm not worried about. It's the rest of my slides that I'm, yeah. I guess we shouldn't be saying that. Anything we're saying is recorded. Yeah. But we'll try to start at 2 o'clock. Maybe I should say that. I'll wait. I'll jump right into it. How many minutes do you have?
waiting for our safety update, right? During COVID.
I did put the hand sanitizer up here. And there are also Lysol wipes for anybody that wants to wipe down. The cube over there.
You know, I guess before you get back, then I thought, I'll take your mask off, but probably just clean your hands before you put your mask back up, because then you're bringing your hands to your face.
Okay, so sanitize when we put it back, before we put it back on.
Yeah, you can do it before if you want to take it off, but at least before you put it back on, because now
All right.
you've touched that stuff, and now you're gonna go close to your face.
Touch your face. Okay, so before we put our mask on, we'll sanitize. Okay.
I mean, you know, if you don't, if you only touch it, it's fine, but you could get close.
So while we're talking, can we take the mask down or keep the mask on?
I guess when we're up there, yeah.
Okay,
And we'll all sort of stay away.
yeah.
Let's see where we're at.
But they'll only be seeing the slides, right?
Right now, they just see the slide, yeah.
Right.
But then
Well,
once we get up, I don't know, I think they might see us on the slides like we did last year.
okay.
This is almost easier. These are cozy. Yes, it's good because we can feel like we're just talking to each other. It's gonna go. Thank you, yes. Oh, it goes, I'm gonna do the introductory slides and it's gonna be, Dr. Foster, and then I'm gonna do my part and then I'll introduce you. And then you introduce. Say slide, or do you introduce the chief? And then, it'll be your last slide, you just say the chief. It's Colson, Chief Colson, or you can just say the chief with them, whatever you feel comfortable, yeah. Just felt it was better to sort of introduce the next person. So that's why I put that in slide on everybody's slide. So that it is less of us going back and forth. Typically, it's been, so we've done, the shortest time we've ever done it is on an hour 10 minutes, and the longest we've like an hour 15. So usually it goes between that and everything. I'm hoping listens. Because our emergency management slides are going to be covered by the chief. And the chief is probably the most known for brevity. He's like, he really does, you know. He's also the person that everyone prefers to watch. He's really fast. Yeah, he is the star. Yeah, it'll be near the warm-up act.
stand in the corner.
Yeah, before, okay. Welcome, everyone, to the 2020 annual update. And I first want to start this by thanking our digital communications department and our IT staff. They've really kept us connected through the pandemic, and we are really grateful for that. I'd also want to extend that to the engineering staff, safety staff, and our environmental services. We often call you guys when things are going wrong, and you always meet our frustration with professionalism and solutions. So we do thank you for that, and we're grateful to you and the families that support you in supporting us. So a lot of the topics that we're going over today, we'll try to be quick. There's the Columbia Suicide Severity Rating Scale. I'll also go over what we do specifically here at Nisby for suicide prevention. There will be the PDFs that I sent out. We'll go over those and review those. Alicia Carreau will go over infection control, and our Cecil Elmore will go over IT, security, safety, and the Chief Golson will go over fire safety and emergency management, and Matthias Quick will go over lab safety and right to know. Recently, I was reading in the Journal of the American Medical Association a study that utilized the Columbia Suicide Severity Rating Scale. And the outcome of the study really said that, we should be giving, in the Veterans Administration hospitals, we should be giving suicide risk scales at the emergency rooms and in the ICUs. And of course, our coworkers at the Columbia Lighthouse Project have known this for a long time, and they've been saying we should ask these questions there. Also to caregivers, to our coworkers, family members, or anyone who's seen these traumas. I used to supervise caseworkers in a clinical setting, and one of the caseworkers that I was supervising was working with a boy who lost his father to suicide, and that was enough for me to really, to watch a boy grow up without his father who he truly loved. It really was enough for me to jump into this and really with full support and get behind this cause. But also having other cases that my coworker had and new intakes coming in, it was really that phenomenon of knowing that the intakes aren't going to stop, and it's the same in our outpatient clinic and in the PERC clinic. When a coworker loses a patient from suicide, the cases don't stop, and as a matter of fact, we'll most likely see increases in cases coming up. So we really, need to focus on training and research and support in these areas. And luckily, to help us, we do have the staff from the Columbia Lighthouse Project. And at the helm is Dr. Posner, who's not only known locally in local governments through her work with the police and the fire departments, but also nationally. She has got the Secretary of Defense's Medal for Exceptional Public Service for her work with our military. So, I'm proud to turn the microphone over to a leader in evidence-based suicide prevention and our colleague, Dr. Posner.
Thank you. Thank you, Marshall. As I said in all the other annual safety updates, it is actually a real honor and a distinct pleasure to be working and helping and partnering with my own institution. So as you said, many of the things I'm going to talk about come from, I've done deep policy work with all 50 states and most countries and every national organization, and we are here to help do that for our own institution in a number of ways. So let me just set the stage for a second. The fact is, suicide takes more firemen than fire, more police than crime, more soldiers than combat, more lives than car accidents. But the good news is it's our one preventable cause of death, and that's what we're gonna talk about. It also touches everyone. I don't need to tell you that. You know, nearly 135 people are affected by every death, and these effects linger across generations because of the silence that often follows. And what it's become, so it has become pretty much minimum standard of care, not only in healthcare, but across schools and police, et cetera. But what we're here to talk about today is a piece that many of you may not know about, that it really has become a vital part of health and wellness for employees and their families. So what we're here today to talk about is how we can take care of each other, how we can care for the caregivers and protect the protectors and the frontline workers. So I don't know if you know this, but if you take a large corporation of 100,000 employees, every 6 days an employee or a family member will die by suicide. Every 6 days. This was prior to COVID. Every single day there will be three suicide attempts. So years ago, if you worked at Wells Fargo or Border Patrol, you would have gotten these questions as part of the effort, the Employee Assistance Program, or Kaiser, or wherever. And now, you know, fast forward to today, Amazon, we work with Amazon because they're using it for their global workforce. They also said, yeah, maybe we can put a Columbia on the side of every Amazon box. Now, the Department of Homeland Security, it's very exciting. We have an app for the Columbia Protocol. They now have their own app, and whether you're Secret Service or TSA, you're going to get the Columbia to save their own lives. So this is being done all over, and what's when we were working before with the Columbia, and I said there's policy in all 50 states, when the policeman or the fireman was doing it, they're not just doing it as part of their job. They have cards that say, ask your fellow firefighter, ask your fellow officer. So, and these days that becomes so important. So I did a piece recently during COVID on CNN, and the next day the American Medical Association called me up and said, yes, we know the Columbia. How do we get it in every doctor's hands? So you see this card with 2 doctors or medical providers wearing masks. Ask your coworker, care for your coworker. So, and this is a very important thing, right? Because medical professional, people who are out there, police, firemen, they often feel this obligation to feel healthy or invulnerable. And we need to break down those barriers of stigma and understand that we're helping everybody when we normalize this and we care for each other. And actually, it's on a later slide, but it was Columbia, the Department of Orthopedics, where they first came and said, how do we get this to doctors? And that's been a model for everybody. And I want to say that, you see how it says employees and their families? I went to give a talk at Sloan Kettering because, you know, it's like blood pressure. And the head of nursing came up to me and said, you know, I used this to save my son's life. And we hear this 1,000 times over. So we're really talking about taking care of each other. And what we've learned when it comes to suicide prevention is that we know that nearly 50% of people who die by suicide have seen their primary care doctor the month before they die. We should be asking these questions the way we monitor for blood pressure. Did you know that many adolescents who show up to the emergency department, who've tried to take their own lives, are not there for psychiatric reasons? So if we're not asking everybody like we do vision testing or blood pressure, we will not find the people suffering in silence. But the very important thing I want to say is that we've learned that we have to have that concept well beyond the doctor's office, because you know what? Many people don't ever get to the doctor's office. So the Undersecretary's office at the Pentagon wrote this urgent memo that we must get the Columbia in everybody's hands because many people never get to the doctor. So here's an example of what I mean by that. Do you know that suicide is the #1 cause of death in construction workers? So we were on the phone with the unions last year, and they said maybe soon enough the safety checks in the morning will be more than the hard hat. It will be the Columbia Protocol. Major League Baseball brought us out to give it to the teams, right? The guy working on the knee in the college locker room or the high school locker room, because we have to
My co-director, Dr. Keita Franklin, ran suicide prevention for the VA and for the DoD, and she was the visionary who now works for us, the visionary who showed the field that we must find people where they work, live, and thrive. We must have a public health approach, so we must be figuring out how we get it in everybody's hands. You heard that story about it helped me save my son's life. So, and orthopedics, we gave this to all the spouses, right? Because this is where, this is the front line of identification. Having a public health approach, we must go beyond the doctor's office. So, one of the things, and I wanted to say also, caring for the caregivers means everybody. So I was on the phone with the New York City Department of Education for public schools because they're ramping up their policy, and we talked about how teachers are people we need to protect as well. So this really extends beyond. Let me just change my slide. Okay. And so how does it also connect to COVID? There are a lot of ways that the Columbia Protocol has been helpful in terms of mitigating the things that we can mitigate. I just said that it is our one preventable cause of death. And when New York State sent workers home, they said this, the Columbia is one way to mitigate the effects of COVID-19, a way to give it as self-help checks. You know that social distancing doesn't have to mean social isolation. Did you guys know that the CDC has said for a very long time that connectedness is one of the most important things we need to do to prevent suicide? And lest you doubt the importance of this or the impact, the opposite, loneliness. Did you know there was a study showing that loneliness is equivalent to smoking 15 cigarettes a day, more lethal than heart disease or obesity? And what the Columbia Protocol becomes is not only a common language, it becomes a framework for normalizing the tough conversations and reducing stigma about talking about things. So it's a way to connect. And what I spoke about, as I said on that, in one of the things I've been speaking about, times I've been speaking to the media during COVID, is that, again, telehealth is fantastic. And we can use the Columbia during telehealth, but people may only get that once a week. It becomes so much more important to rely on peer-to-peer, which we knew before, and these are lessons we've learned from wartime, that battle buddy and checks and being there for your neighbors. And this is a way that we really can make a difference. So you can check in on your neighbor, on your coworker, on your peer. And the other thing that's important about that as well is that we've learned from other past traumas. The data is very clear that when you're helping others and you're asking and you're being there for them, it actually helps you heal. The Parkland community said that about the Columbia. Now we know we don't have to sit back and feel helpless. We can actually be here for each other, and that becomes all the more important now. And you guys may know, right? This was the beginning. This was a data point from March that crisis line calls went up 900%. A lot of essential workers worrying about the things you would think, money, loneliness, et cetera, et cetera. But these were the people that actually had the will to pick up the phone and call. That's the problem. A lot of people suffer in silence, which is, I'm just bringing that point home about why we have to be asking our friends, our loved ones, our neighbors. And we know that healthcare workers rank third for depressive episodes of all occupations. We knew back during SARS, right, that there was lots of traumatic stress. We know now from COVID that this was in the beginning in China. 71% of frontline workers reported symptoms of psychological distress, at least half depression or anxiety. We can't even imagine what the stressors are. But again, this is something we can actually do something about. And one of the other things is that, people weren't asking. One of the reasons were they didn't know what questions to ask. They didn't know what to do with the answers. They didn't know if it was going to cause somebody to be suicidal. It's actually the opposite. When somebody is suffering, they actually want help. They want to be asked, and every Columbia is connected to next steps. So it's New York State said it's proscriptive enough for the non-professional and flexible enough just to inform clinical judgment. So that policeman who is deciding whether to take somebody to the ER has a proscriptive formula. The ED triage nurse who has to decide who to put in that ED hold room has a proscriptive formula. And all high-risk means, which is only 1% of people, all high-risk means is getting a next step and a further evaluation. And I want to say that I always talk about the benefit to the system because it's redirecting tons of resources. Only 1% of people need that next step. Millions of dollars are being saved in resources like those ED hold rooms. But you know what happens when a policeman takes somebody to the hospital unnecessarily, or that person gets in that ED hold room unnecessarily? It shuts them down from treatment when they actually need it. So so people would say, I didn't know what questions to ask. They also, we don't have a perfect formula. We may never have a perfect formula. So people used to say, how can I ask? People have said for a long time, because there's so much evidence behind the Columbia, it frees you up to be able to ask because we have a responsibility to do so and because it's deemed the most evidence supported. Somebody said you don't get into trouble for a bad outcome, you get into trouble for not doing something. So, and it's not just in healthcare. When MIT had a suicide, like every university does, the Supreme Court brief wrote about it as the minimum reasonable standard. What that means is the custodian, the college professor, the resident advisor, they're freed up to be able to ask the questions, and that's really, really, really important. And the other reason is, why has this been chosen as the global language? One reason is it's the first time we have evidence-based thresholds for imminent risk. Before, we didn't know who to worry about, and that prevented us from finding the needle in the haystack, right? And that was really important. Another reason, for example, it's the first time that we're asking about all suicidal behaviors. What that means is if you were lucky, you would get asked about a suicide attempt and then you missed the person that bought the gun or wrote the suicide note, things we absolutely cannot afford to ask. And I want to just tell one quick story about this public health approach. I was giving a talk to the state of Connecticut, and this huge system said, we gave it to the janitors. And this clinician from the VA said, exactly right. I'll never forget that case where the only person that vet spoke to was the janitor, right? Now there are states where it's policy for custodians and front desk workers. And so now everybody can be part of the solution, and we can all be there to help save each other's lives. So just, to end, there's an app in the App Store, both for Android and otherwise. And there are lots of ways. We always say that it's just as important to have feasible and innovative delivery as it is to have the right questions. So posters behind water coolers, in Tennessee, they have badge buddies. So everybody in these schools and hospitals are walking around with like a thing around their lanyard, I told you, Amazon might put it on the sides of buses. In New York State, we're talking about billboards and sides, and how do we get it in everybody's hands? And these things don't replace each other, they just complement each other. And people learn from each other, so that's the beautiful part. People can learn from their peers, learn from their coworkers while also saving their lives. And the one thing I would say is when we begin to normalize this like blood pressure, it begins to really save many more lives because you cannot rely on people showing you signs. How many cases have all of us heard about or experienced directly? I didn't know, right? And that's why we have to, people who are not suffering will not mind being asked. And when you do ask people who are suffering in silence, it actually will help save their life. And it is really empowering. This is a story that empowers everybody to be part of the solution. And you can see, this is what things across the world look like. Ask your fellow officer, ask your community member, ask your spouse, ask your kids, right? These are things that everybody can have in their toolkit to help save lives. And then finally, again, this is certainly importantly part of the safety conversation, right? just like infection control. You know, at one point in history, we learned to start washing hands to save lives, and now we can start asking to do the same. So thank you for that. And we are here, our center, as a 24/7 service center for any questions anybody might have. And again, it's my honor to be talking to you all today.
Thank you, Dr. Posner. So, of course, here at the Institute, we always say that everyone is responsible for preventing suicide with our patients, and that includes, like, things that you leave around the Institute, and, we have to be careful and cautious and make sure that we're monitoring equipment that we have or that we have left around. On the inpatient units, for inpatient suicide, 75% of them are done by ligatures. So our oversight agencies have required that we do risk assessment for ligatures. Part of that risk assessment, we saw that there were risk in the bedrooms, bathrooms, public bathrooms, hallways, and day rooms. And here are some of those pictures. This is a doorway. This is other ligature risk in the bedrooms. On our inpatient units, ligature risk in the bathrooms, the day rooms, day room door, day room furniture. And this is important for inpatient staff to know, as well as other staff, support staff, everyone else. These are areas that we should be watching and trying to change if we possibly can. The hallways, these are ligature risk there, and then there are blind spots in the door in the dorms, and there's an observation mirror to watch that. So some of the things that we do to mitigate that are any patients that are considered a risk are put on one-to-one. Also, they have 15-minute observations, and there's observation of day rooms directly by staff or camera 24/7, and observation of dormitories when patients are in their bedrooms. So self-locking and self-closing doors, observation mirrors for the blind spots, and admission search for removal of any objects that could be a danger when patients are coming in. So, of course, how do we assess risk of patients that are here? Through the Columbia Suicide Severity Rating Scale. We do that on admission. We do that upon discharge and at any time when there is an incident. And in the outpatient department, they do it, of course, on admission, and they also do it before and after any hospitalizations that might happen while they're in the outpatient department. Of course, the plan, the Nisby follows the Suicide Safer Care Protocol, and the plan addresses hospitalization versus increased frequency of visits, one-to-one observation for high-risk patients, and communication of patients' risk to family and treatment team, and assistance with stresses like housing and legal and family and medical issues. So, of course, their education is a part of that. This is part of that education, but also new staff coming in, working on the inpatient units will get suicide risk prevention, patient observation, training in dangerous objects, levels of activity, search policy, hands-off communication, and missing patients and escort policies. All these policies are also on our service net. Of course, patients are assessed at discharge, and also when they're doing referrals to the outpatient department, they have to be seen within a week, and that's a really risky time. Well, a patient is going from not being able to access anything to hurt themselves to going to a community setting where they have access to anything possible. So we really want to make sure that we're providing wraparound services at that time. And, how do we check up on that? Our utilization review nurse makes sure that those assessments are happening upon admission, upon discharge, and whenever there's incidents. And also our nurse administrators are talking to our therapy aides about, specific patients when they're doing a one-to-one. What are the issues with that patient and what needs to be done? And, they're monitoring that as it happens. So, anybody developing suicide plans for people needs to make sure that they have wraparound 24/7 services. And we encourage everybody to not only include talk lines, but text lines as well. And, we mentioned this last year, but anybody that wants to get this information out about the crisis text line, please do. They have a website where there are posters and other information that you can put around clinics, schools, and other areas for people to be able to text in a crisis. So Nisby developed a new respect policy this year, and I really like the definition of respect. I don't know if I could define respect if I thought about myself, but when I looked at this, I really thought, yes, that really does it. And so the way they define respect is to look upon or interact with esteem or honor, expressing consideration and courtesy, the active demonstration of relating to others with regard and consideration for their feelings, rights, and differences. So, and they define consideration as thoughtful attention and civility as courtesy and politeness towards other human beings. And of course, the basic premise of the respect policy is that all staff, any title should maintain a polite and respectful demeanor with all individuals, whether patients, visitors, co-workers, collaterals, while representing Nisby. And respectful and courteous behavior should be evidenced in all work and interactions and communications. So, in addition to that, also the governor's office just sent out, we got it this morning, and we sent it out to all of you, Gender Identity in the Workplace, a toolkit for New York State employees. And, I've always felt great about being in New York, and they seem to be a leader in the area of human rights across the nation and acceptance. And I was glad to see this coming out this morning. And part of it says, while it is expected that all New York State employees will treat their transgender and gender nonconforming colleagues appropriately, supervisors and human resource personnel have an even greater responsibility. And it reminded me of a study I did when I was in graduate school. I did a group research study, and we were looking at the efficacy of GSAs, which GSAs are gay straight alliances. If you don't know, gay teens or same-sex teens or LGBTQ teens, basically, they have a really difficult time with acceptance in school, even in their own families. And so there's high rates of runaways and a lot of other problems, school dropouts. And we looked at some of the secondary data that we were going to utilize in our study with our team, and one of the studies that we came across was a study done in Canada that showed that 70% of the students in the school said that they heard their teachers say, not students, not people outside of the school, but their teachers say negative things about their fellow students that had same-sex preference or were had gender identity. And we're working with gender identity. And they, LGBTQ, I guess would be the appropriate way to just say that. But, that really was profound to me, and it made me realize that, educators and everyone really needs to step up and make sure that acceptance is happening. And, New York State is telling our supervisors, everybody that, and I'm glad to see that. And they did say what not to do, and that's don't force an individual to discuss or explain their transition with other employees. It's really, it's like, it's really up to that person to discuss it if they want to. So, let them and applaud them if they do want to discuss it and help other people, but it isn't up to us whether or not they want to do it. If you feel like it might help, you could ask them in private if they would be comfortable discussing it, but otherwise you don't force them to do that, or you don't do that for them or tell other people for them. So, and then continuing to intentionally refer to the individual using a name or pronoun that they don't want you to use is also something we should not do, and we shouldn't force employees to act in a way inconsistent with their gender identity. So those are some basics from that, but I really encourage everyone to take a look at that and make sure that we're following those rules when it comes to both patients and staff that we work with that have gender identity issues. Okay, so employee-patient relations, we want to make sure that we're keeping appropriate boundaries. Never borrow patients' money or property. Never encourage or condone illegal behavior, and don't engage in sexual relationship, obviously, with patients. And discuss any potential conflicts with your supervisor or team. If you've had a previous relationship, business or intimate, with someone that comes in for help, then make sure that you're letting people know, and that's important. So the Medicaid PDF isn't new. We sent it out again, but for those of you that don't work with Medicaid, it really just talks to program oversight. If stay in close contact with the people that have oversight of your program, and if they notice mistakes, make sure you're fixing those right away so they don't start to look like waste and abuse and fraud. We want to make sure that we're working closely with the people that monitor our programs and we're following their instructions as soon as we feasibly can. So for language access, we got a new telephone interpretation service this year. We put stickers on all the phones that in areas that use it, and we also put it on our service net. We've seen an uptick in our utilization of telephone interpretation, and I guess that's probably because our bilingual colleagues aren't right next to us now during COVID time, but it's increased at least 3 or 4 times the amount that it was last year for telephone interpretation. So we encourage staff to use that. We want to make sure that we're providing service to our patients and families the best that we possibly can. And please let us know if there's any issues with that as well. Central Office OMH Bureau of Cultural Competency is constantly asking us, are we having any problems with our providers? So if you do, please let me know and I'll let Central Office know. Also, we updated our volunteer language bank this year, and so thank you to everybody that's on that volunteer language bank and offered to continue to stay on that. We sent out a couple more PDFs on pharmaceutical hazardous waste, and some of you got controlled substance training. Pharmaceutical hazardous waste really talks about the waste stream of medication. So if you do handle medications, take a look at that. Also, work with our infection control nurse and Mateus Quick on understanding that. And the controlled substance training, Mateus is going to talk to you guys about that a little bit later, but we're considering including that for our new staff that are coming into labs. So up next, we have our infection control nurse, Alicia Carreau, and she's going to speak with you guys about infection control.
Thank you, Marshall. Okay, I have a few slides to go through. The first slide I want to start with, I think this is my most important message I want to give. It's everybody here. We keep each other safe. It's not one person or 2 people or a group or a task force. It's everybody. From wearing masks when it's not comfortable, to staying home because you have a cold and it's probably not a big deal, but you never know, to not sharing lunch with the colleagues like you usually like to do in a small room or in an office area. It's all of these efforts together is what has made it possible for Nisby to stay safe and for everybody to continue coming here. It's difficult. Some people are told you need to come into work, and other people are told, no, you can't come into work. So it's just following what we have in place, even though it's difficult, is what is going to keep it safe here. And it's really, I think everybody's done a terrific job. It's been a long time. It's been, 10 months? It's not over yet, but we just need to keep plugging along, and we'll get through this. So I'll go through some of the slides. It's not too much new here. Some of the slides have a lot of words. I do have my email on it. The infection control email is probably the best. If anyone has any questions or want to discuss something with me, to contact me that way. So again, don't come to work if you're ill. Even if you don't think it's a big deal, it's much better to stay home than to come in and to infect other people. If you are ill, always you let your supervisor know. If you're going to be out for more than a few days, let your HR department know. If you have testing done, please let me know. Currently, Nisby is not providing testing for employees, but we are going to be able to provide some testing for some employees very shortly. There is plenty of testing available. I have the website there, but if you just Google nyc.gov COVID testing, you'll get the page. You put in your address or what area you want to look for testing, and it'll pop up all the testing availability. Of course, you have health insurance, and there's no copay. The copay is waived for COVID testing. Again, face masks. Face masks all the time from when you come in. We ask anybody who is going to interact with patients or the public to wear a surgical face mask. So if you have your cloth face mask, the one you like, you wear that at home, you come in, that's fine. But when you get to the hospital here, please switch over with a surgical face mask if you're someone in your position which will interact with patients or public. Okay. In addition to face masks, anybody who will be interacting with outpatient participants, we consider these, although they're screened, the COVID status is unknown. So as an extra protection, we'd like you to wear eye protection. That's either goggles or a face shield. And in addition, any of the patients that are admitted are put on 24-hour isolation, and that's also when eye protection would be indicated. Okay. Again, I talked about staying out if you're ill. The rules vary between having symptoms, not having symptoms, being essential, not being essential. One of the easiest way to think about if you are essential, if you have been here on site working throughout this pandemic, you are essential. If you've been able to work from home, then you are not essential. Doesn't mean that your position isn't valued. It's just what was put in place of who would be necessary to administer patient care. So whether that's the nutrition, safety officers, environmental services, nurses and physicians, that group. Okay, so if you have symptoms and you're essential, you need to stay out a minimum of 7 days, and you need to be without a fever for 3 days prior to coming back. If you're no symptoms, but you have had a positive test, again, it's 7 days. Non-essential staff, you stay home in quarantine for 14 days. Exposure. There's a lot of questions about exposure. There's a lot of spread in the community, a lot of kids in schools or kids coming home from colleges. The key word for exposure is it has to be direct contact. So it's not somebody you have contact with and they have contact with someone else. It's direct contact. So you need to have direct contact with the person, and that close proximity, less than 6 feet, a longer duration, more than 15 minutes, and the person has to be confirmed COVID positive when you have contact with them. In addition, you need to not be wearing the PPE that is recommended. So with that, there should be no exposure at work. Exposure would happen outside of work. And then the work restrictions, again, if you're asymptomatic, essential staff, you come to work if you're not showing symptoms, but non-essential staff, you stay home in quarantine for 14 days. Travel, it's the holiday season and everyone wants to travel, and you see the lines around the block at City MD getting their COVID test, thinking that that's going to make them safe to go home and travel and have Thanksgiving dinner with the family, and it's not. Travel is not advised. Travel is very high risk. Even at the time you have your test, and then you get on the plane and you go home and you mingle with your family, you might be infectious at that point. If you do choose to travel, discuss it with your supervisor. Your supervisor is the person who grants your time off. Please let them know your intentions. Again, now there's travel restrictions. Essential workers, if you're returning to New York within 24 hours, you need to acquire a COVID test, and you can come to work pending your test result. Non-essential workers, it's a 14-day quarantine, but there's an option to test out of the quarantine, and I have it there. 3 days before you leave, you test, and then you come back, you quarantine for 3 days. Day 4, you test again. And when you have your 2 negative test results, you can return to work. I know, again, it's a lot of information. Again, if for specifics, you can questions and situations, you can email me and I'll go over it again. Patient participant screening. So everybody that's coming in the building is screening. The staff screens for symptoms, and all patient or participants are screened for their outpatient appointments. They should be screened before they come in, the day before, and then again when they're met at the door. We ask that the participants are escorted at all times. When patients are coming into the unit, all patients coming into the unit have had testing and are PCR tested negative. If patients are admitted through the emergency room, they are tested in the ER prior to coming into PI. If they're coming in through outpatient, they need to have a negative PCR test within a week of coming in. And then on the day of admission, they have a repeat PCR test done, which is run stat over at PH, so we have those results back. In addition, all participants that are being admitted, the first 24 hours on the unit, they are kept on isolation. I think I have that there. Hand hygiene, it's again, 20 seconds, wash your hands well, clean your hands often. We have a lot of sanitizer throughout the hospital. Please use it. Touch the elevator buttons, clean your hands. Open the doorknob, clean your hands. Okay? Occupational exposures. So if you have an exposure, needle stick, a splash to your eye, a chemical splash, an animal bite, any type of exposure, you want to let your supervisor know right away. In general, you clean the area with soap and water. If you work for the DCM department, some areas have different protocols. If you get an exposure to your eyes, you want to clean your eyes, irrigate saline or water. Notify safety. Now, 5100 is the general number you call. Safety will answer, safety. So you have a cut on your finger, you want someone to help, you want someone to guide through, you need some assistance, you call 5100. If it's an emergency, it's 5555. The phone will be picked up on that moment, and there will probably be an overhead page announcing what type of emergency it is. So you can distinguish that. Safety, for any exposure, safety will notify me if I'm here, and there is always a nurse on call 24 hours, 7 days a week, and we have a cell number, and safety will call the the nurse administrator on call to come assist. We want you to go to the emergency room for evaluation and treatment if needed. Nobody will make you take any type of treatment. They're going to assess what your risk is and make a recommendation, and then you can decide what you would like to do. But if you decide to take the prophylactic medication post-exposure, it's recommended to be taken as soon as possible, ideally within 2 hours of the exposure. We want you to complete an accident report. This is located on the ServiceNet. And again, by alerting safety and alerting the nurse administrator, we can help you go through and complete that report. Waste, sharps containers, I think people are pretty good throughout the Institute. Things that are sharp go in the sharps containers. So all your needles, your slides, anything sharp like that. Additionally, blood tubes go in sharp containers. Be careful when you use them. Don't let them get above the fill line. You call environmental services. They will take the old ones and give you a new sharps container. Red bag use. There is an excessive amount of unnecessary red bag use here at PI. If you see what it's used for, pathological specimens, animal waste, body parts, in the clinical area, unless the items are soaked, caked, or dripping with blood, they do not go in the red bag. Okay, they go in regular trash. Universal precautions, again, face masks. Whenever you are not alone in your office, you should have a face mask on. Or in a case like where we're very far apart to talk, you can have, but you should have your face mask on. The N95s are used for clinical staff to wear when they are taking care of COVID-positive patients or when performing an aerosol-producing procedure. Gloves do not replace hand hygiene. Please do not walk around the Institute wearing gloves. It gives you a false sense that your hands are clean and you will spread more germs. Gloves are to be worn when you have a risk of coming into contact with blood or body fluids, or if you're using some of these super sani-cloths or cleaning products which are harmful to your hands. And of course, whenever you remove your gloves, you clean your hands immediately. Goggles, I talked about goggles or face shields, outpatient when you're interacting with outpatient participants or you're interacting with patients that are on observation or if they were on isolation. Then you can wear goggles or a face shield. Also, if you were collecting the COVID PCR specimen, it's recommended the face shield, the face mask, a disposable gown, and gloves. And I talked about the super sani-cloths. These are the things that are great for cleaning your area, cleaning your equipment. Use gloves when you use the product. Flu vaccination and TB testing. I know many people are not on site, and so they missed one of our flu clinics. If you have had your flu vaccination done outside of PI, please send me a record of your vaccination. I have to give weekly reports to OMH of the compliance rates, and we are nowhere where we should be. So if there are people in-house or coming in and you haven't had your flu vaccination, I will gladly give you a flu vaccine. You can contact me for that. TB testing, we did TB testing annually, and for some of the folks that work with the in DCM, they have TB screening and testing done twice a year. So just to conclude, again, stay home if you are ill. Don't risk infecting people. Get your flu vaccine. Act immediately if you have an exposure. Dispose of sharps and garbage properly. Clean your area, your equipment, in between patient contact. It's always a good idea, even come in the morning, clean your area. Get TB screened and tested. And again, everybody, I know it's been a long time and people are kind of tired of it, but we really need to keep going. Wear the face mask, clean your hands, do the screening. Only eat when you're in your office by yourself or in the multi-purpose room, and we'll get through this. Thank you. Next up is Cecil Elmore with a presentation on IT. I think they're there.
Well, it is a privilege to finally be here. For those of you who previously would see Chris Stanley speaking about Psychiatry and cybersecurity, Chris is still supporting Nisby, but I am now, as the Assistant IT Director, to be on site when we all do come back. So I'm looking forward to meeting everyone in person. In this presentation, what we're going to do is we're going to look at some of the Hipaa requirements that we are required to observe to ensure that the information that we collect remains safe and secure. And then we're going to go ahead and talk about the cybersecurity policies and standards and best practices that we should all be observing in our daily work to ensure that we keep our systems up and functioning and the data that we have in our systems safe. So we will begin first with a presentation. It's a pre-recorded presentation on Hipaa. It will last approximately 14 minutes. And after that presentation, I will speak for approximately the same amount of time on certain other aspects of cybersecurity.
In this video, we will be going over the protection of data at Nisby. Hipaa regulates how we collect, use, and store data here at Nisby. The goal of this presentation is to give you an understanding of the privacy and security rules put in place by Hipaa, and also to provide you with the information about steps you can take to keep information secure. Hipaa stands for the Health Insurance Portability and Accountability Act. The original law was enacted in 1996 and was intended to establish national standards for the protection of health information. Subsequent additions to the original law have been aimed at regulating the use of digital medical records. There are many components to Hipaa, and the actual laws can be pretty complex. For our purposes, we will just be going over some specific components that directly affect how we operate at Nisby. This video is only intended to go over the most relevant aspects. The first thing we will cover is privacy. Applies to protected health information, or PHI, created, used, or disclosed by a covered entity. The privacy rule establishes who is permitted to use, disclose, or access information. It also requires that only the minimum necessary information be used for any permitted action regarding PHI. These are some terms that you should be familiar with. The privacy rule protects all individually identifiable health information. held or transmitted by a covered entity in any form or media. Individually identifiable health information is any health information for which there is a reasonable basis to believe it can be used to identify an individual. PHI is comprised of health information and personal identifiers that link it to a specific person. This is a list of common personal identifiers. If any of these are linked to health information, then it's protected health information. Health information that is not paired with any personal identifiers is considered de-identified and is not subject to HIPAA. Now let's look at the term covered entity. A CE is any organization that is subject to the privacy rules established by HIPAA. CEs can be healthcare providers like hospitals and pharmacies, they can be insurance related, or they could be something like an intermediary billing service. All students, interns, registered volunteers, staff paid by OMH, Columbia University, or RFMH, or others that work in some capacity under Nisby or OMH are considered part of the Nisby workforce and must comply with HIPAA regulations. A business associate is a person or organization that provides a service to a covered entity involving access to PHI. The privacy rule requires that a BA contract includes specific safeguards in place to protect PHI. A business associate contract is not required for disclosures from a covered entity to a researcher as long as patient authorization has been obtained. A CE can use and disclose PHI for treatment, payment, or healthcare operations without written authorization. Any information disclosed must follow the minimum necessary rule, which states the use of the minimum amount of information necessary to achieve the intended purpose. Research at Nisby requires a signed patient authorization or a waiver of authorization from the IRB. HIPAA is not the only thing to consider in terms of protecting patient information. There are also New York State and Columbia regulations that apply to specific situations. The ones listed here are just some examples of additional laws that protect patient confidentiality. Contact the HIPAA officer to find out specific laws regarding your specific research information. There are a few common sense measures that you can take to ensure that patient information is not accidentally or carelessly disclosed. Don't discuss PHI in a public place or with people you don't know, and don't use patient names in a public area. Don't leave labeled specimens unlocked or in a visible space. Limit access to areas where patient information is kept. Use only secure fax machines when sending PHI, and don't leave identifiable information on voicemail or an answering machine. Finally, if you have to send PHI, send it in a sealed envelope that doesn't include Nisby in the address. Now let's look at the security rule component of HIPAA. The convenience of electronic patient information comes with an increased risk for that personal information could be stolen or accidentally disclosed. In recognition of these risks, HIPAA included the security rule which applies to PHI stored or transferred on electronic devices. This is referred to as ePHI. It does not apply to written or oral patient information. Security rule requires an institution to have policies and procedures to manage the selection, development, implementation, and maintenance of security measures to protect ePHI. This includes administrative, physical, and technical safeguards. We're going to go over how we here at Nisby comply with the security component of HIPAA. This section will also include some New York State required information security as well. Passwords are covered elsewhere in this video, so we can start at the physical safeguards. First, only authorized users should have physical access to Nisby devices or personal devices that access PHI. Never leave a laptop or mobile device unattended. When traveling, any electronic device needs to be secure. Devices should never be in checked luggage. Users with mobile devices containing access or accessing PHI must make sure that data on the screen cannot be seen by unauthorized persons. Here's an example of how a small oversight in the security of a device containing PHI can create serious liabilities. In 2012, the Alaska DHHS had to pay $1.7 million for Hipaa violations after an employee's car is broken into and a single unencrypted USB device containing the EPHI of 2,000 individuals was taken. It's easy to think that something as small as a USB device doesn't present a huge security risk, but the reality of digital information means that every device needs to be used with caution. Small shortcuts like not taking 30 seconds to encrypt a portable hard drive is needlessly reckless when you consider the danger that it presents. In this case, the loss of the device led to a complete investigation into the DHHS. This leads us to the next section, the encryption of all devices. Encryption is a method of protecting data from people that you don't want to see it. While there are many methods of encryption, they work on the same fundamental principle. Data is scrambled using an algorithm and unscrambled with the use of an encryption key. Normal, unscrambled data is referred to as plain text, and encrypted data is referred to as ciphertext. Encryption is an effective way to keep data secure. It's also very easy to take the basic steps necessary to ensure that you are correctly encrypting any device you might be using. There's really no excuse for storing any plain text data, be it PHI or otherwise. Data security is generally broken down into two categories. Data at rest refers to an inactive data stored physically in any digital form. This includes things like databases, spreadsheets, or archives. Data in transit refers to data actively moving from one location to another, such as across the internet or through a network. Encryption is required for data at rest in regards to desktops that access or contain any state entity, personal or private or sensitive information, data stores containing PHI or Nisby information, any mobile device, state-issued or personal used to access any state entity information, and all portable devices containing state entity information. Encryption is required for any transmission of personal, private, or sensitive information when connecting to the state internal network over a wireless network and remotely accessing a state internal network. BitLocker can be used for full disk encryption of Windows devices as well as the encryption of USB drives. BitLocker is only available in Windows 10 Pro, Enterprise, or Education. Detailed instructions for the proper use of encryption can be found on the CIT website. Mac users can also find information about how to use File Vault 2 for encryption. iPhones and virtually all Android devices have built-in encryption features. You need to check your phone settings to make sure you are taking full advantage of these features. Your phone should be password protected and set up to have screen lock after 5 minutes of inactivity. Your device should also be set up so that all data is wiped after 10 incorrect password attempts. There's more information regarding mobile device encryption on the CIT website. If you have any issues with ensuring that your personal device is correctly encrypted, please contact the service desk. The loss or theft of any device containing Nisby data must be reported immediately. A timely response to potential IT issues can be mitigated if it's caught early. Next, we'll be going over the secure use of email. Nisby uses Office 365 as a secure email service for all its business. You should never use a personal email for anything involving PHI or any other Nisby-related business. You can encrypt emails in Outlook by including the hashtag encrypt in the subject line. You should also include this disclosure when sending PHI within an email. CIT requires that all systems be registered. New York State IT standards require that a state entity like Nisby create a record of all systems and data contained within those systems. This means IT needs to be made aware of any database, mobile device application, or any other system that's used for Nisby business. You can find a link for registering your system on the CIT website. You will be asked for all the information that's needed to comply with system registration policies in place for Columbia University and New York State. If you are developing a multi-user system that will be used for research, keep in mind that the data you store within that system will dictate the level of security that it requires. Part of system registration involves an assessment and classification of data. Anything containing PHI will need to abide by stringent security guidelines. You should only be storing essential information necessary to accomplish your research goals. The last part of HIPAA covered in this video will be the breach notification rule. A breach is a prohibited use or disclosure of unsecured PHI under the privacy rule that compromises the security or privacy of a PHI. Any breach is thoroughly investigated to determine the nature and extent of the information disclosed. Steps must be taken to minimize security risks, and all patients affected by the breach, regardless of the quantity, must be notified. Again, it's important that you go to IT if you suspect any loss or theft of information. Media notice may be indicated if the breach involves more than 500 people. Federal government notification of breaches of more than 500 records must occur within 60 days of the breach, and a business associate must comply with the same rules and must notify a CE if a breach has occurred. There are specific penalties in place for failing to protect PHI. The penalty amounts are based on the level and intent of the breach. All accidents are classified and penalized according to their type. Examples include faxing or emailing a document, sending lab results to the wrong person, using PHI without proper security credentials, or failing to encrypt a mobile device. These are a few examples of how a breach might occur. All workforce members in Nisby are required to understand the privacy, security, and breach notification components of HIPAA. PHI and ePHI must be protected. PHI for research purposes requires an authorization from the IRB or a waiver of authorization. How we use and disclose information is outlined in the consent form. Remember that PHI can be used or disclosed for treatment purposes with a few constraints as long as the minimum necessary standard is met and we obtain patient's assent. If the patient objects, the provider must understand the actual limits on disclosure.
Okay, so that completes the portion of the training on the HIPAA. Obviously, it's extremely important that we protect the electronic personal health information that we have within our systems. Failure to do so can be extremely expensive and have many consequences, both reputationally and financially. So, second part of this is just to bring this right up to speed. Where are we today in 2020, right? Because it's alarming. I've been doing cybersecurity for 10 years, and this is a shifting field. And just to share some things, these are some news headlines from the SANS Institute, which is a very reputable cybersecurity organization. And these are the headlines just from November, right? We're talking about Hendrick Health in Texas, operating under electronic health record downtime procedures after an incident. Sonoma Valley Hospital, also operating under EHR downtime because they were hit with ransomware. Florida's Advanced Urgent Care notifying patients that their confidential information has been compromised, again, due to ransomware. And Minnesota's People Incorporated Mental Health Services notifying their patients that their confidential information has been exposed, right? So what we're seeing is that right now, organizations like Nisby, health organizations, are in the target of these malicious actors. Looking again, other reputable sources, IBM, Pullman Institute, right, Trend Micros. In the past year, 700 healthcare providers were victim to ransomware, right? This is a real threat to our organization. And in the earlier presentation, we talked about the Alaska DHHS that was fined $1.7 million. Well, that was a little old. The reality is now that a data breach in the healthcare industry, our industry, costs an average of $6.45 million, right? So there is motivation here to ensure that we all act in a manner that is very responsible, following best practices, guidance, policy, to avoid this type of situation. Last slide with some statistics again, and this comes from the Verizon Data Breach Investigative Reports, which does a very thorough analysis of the attack vectors that malicious actors use. And what was very interesting when I reviewed this past year, the most recent report, is that 37% of credential theft breaches use stolen or weak passwords, right? Entirely preventable. 25% involves phishing, right? You know, we've been talking about phishing for years, right? But the reality is, CUIMC, their ISO office, just did a phishing test last month. 21% of the recipients clicked on those phishing emails, right? That's 1 out of every 5 people clicked on these emails. This is the way that ransomware happens, that the malicious actors get into our systems, right? And again, it's not anything about fancy, expensive technology preventing this. It's the way that we act as users of these systems, right? And just completing this, number of confirmed data breaches in the healthcare sector, according to the Verizon DBIR, increased by 71% in the past year, right? So we need to be vigilant and aware that malicious actors are trying to get into our systems. Right? So what can we do about this? Right? Well, now's where we talk about the policies and the standards, right? We've probably all heard this before. Let's start with passwords, right? In order to comply with federal, New York State, Columbia policies, Nisby has established password standards. Passwords expire every 6 months. Passwords cannot be reused, right? Passwords must consist of at least 10 character, a minimum of 10 characters in length, consisting of 3 of 4 different types of categories: lowercase characters, uppercase characters, numbers, special characters, right? We want passwords to be complex, right? You know, especially what we want to avoid are things like this, right? Where we're using obvious things like birthdays or names of family members, right? Those are very trivial passwords. It's an easy in for malicious actors, right? We don't want to use the same password for different accounts. And that's a mistake that all too many people make. They get on their social media, they have the password, but they use that same password for all their banking. They use it for their Nisby business accounts, right? And that leads to a situation where one exposed password, one hacked password, gets reused by that actor in all the accounts owned by that person. Right? So the third one, consider using a phrase that's easy for you to remember. And we'll talk about that right now, right? And I think some of this is, you've probably seen an earlier presentation from previous years, talking about using passphrases, right? If you look at number 2, you can think of a phrase, you know, if it's sunny, I'm going to walk. If it's rainy, I'm going to drive. You know, concatenate those words together, be creative, substitute special characters, numbers in place of letters, right? And get a nice passphrase, right? Make them unique. And point number 1 is that there's more in the authentication game than just passwords, right? Many of us with the smartphones that we use, we have the ability to use a thumbprint, right? That's something we are. A facial recognition scan, right? So there's more than just passwords. There's also other types of tokens that we can use for authentication. And I'm going to talk about this more later. I just wanted to put that out there. So here's the challenge, though. Traditionally, we said, okay, use a complex password. And the average person has 90, many people have more than 100 different types of accounts, personal, business, right? How do you possibly follow these guidelines with complex passwords and unique passwords for every account, right? I can't remember 100 different passwords, right? And most of us can't. The recommendation is to use a password manager, right? Personally, that's something I do and many other people do, right? You only have to remember one complex password, because what this password manager or password wall, it does, is it stores all these complex passwords and unique passwords for all your different accounts, encrypted securely in one place, right? Leaving you just to remember one complex unique password. So that is a recommendation, something to consider, a solution. There's a number of there's quite a few different password managers out in the market today. Here's some recognized ones. The one I use isn't there, but that doesn't matter. Pick the one that meets your needs. But what's more important than just passwords is something called multi-factor authentication, which many of us are already using, but I'm going to speak in a little detail because this is something very important to protect our systems and our data here at Nisby. So multi-factor authentication, just very simply, is something you know, something you have, something you are, right? It's an authentication system so that instead of using just one way to one of these three means, right? The password, which is traditional, got my user ID, got my password, I'm going to get in the system, right? Now we're combining it with another factor of authentication, right? And we'll talk about the tokens later. Number 3, don't worry. We're not looking at biometrics here at Nisby, right? We aren't going to use for multi-factor authentication, okay? Just want to alleviate any concerns up front. So, the important thing about multi-factor authentication is, if you think about it for a moment, if your password is compromised, but yet you're getting a randomly generated code that randomly gets generated every 60 seconds on your iPhone or on a key fob, right, that you possess, that external actor who has gotten your stolen credentials won't be successful in getting into the system because they don't have the other piece, right? Yeah, and you can just see right here, this came from a Microsoft blog talking about, one of their engineers talked about the rate of compromise of accounts using NEMFA, multi-factor authentication, is less than 0.1% of the general population. It's an exponential increase in security. It's a real return on investment. And the reality is most malicious actors will move on to targets, easier targets. They're looking for the low-hanging fruit, right? So let's talk about remote access and the role multi-factor authentication plays, right? So if we go back 1 year, right, we would all, most of us, right, come into the office every day. We'd sit at our desk, we'd plug into our network, and we worked locally, right? The building was full of staff, right? And all it took was just a user ID and password, and we were in the system, right? And there was a certain amount of security with that in the sense that we were there, physically there. But the reality of where we are today, right, is we are working remotely. It's the exception that we're in at work. So how do we provide that extra level of security? Because when someone's outside and coming into our system with all our precious data, right, how do we know that it's not an actor who has just taken stolen credentials who are coming in, right? Because that's a weak level of security. So instead, what we do, whoop, I jumped ahead here. We have the remote access multi-factor tokens. Let me speak about this. These are just, if we're talking on a smartphone, right? It's just an application that gets loaded. It can go on a tablet, it can go on a phone, it can go on an Android, it can go on iPhone, right? Every 60 seconds it generates a random code, and you use that in addition with your user ID and password. You can get a physical token also, right? Maybe it's a little more old school, right? Not as convenient. It's going to take several weeks if you choose to get a physical token, right, for multi-factor authentication. And we'll talk about how you can go ahead and ask PsyIT
or ITS to provide that to you. One other quick comment. On the phone, putting the token on the phone, it's not accessing your other data. It's just generating a random number. So some people are concerned about that. Just wanted to mention that very quickly. Okay. I wanted to make the comment that as we all work remotely, there's actually 4 types of remote access. Some of us may be using multiple types of remote access. There's cloud-based entirely in the cloud. You aren't even getting the Nisby system. I think in previous years there's been some discussion about the Office 365 offering and that it's a secure email. There's also the virtual desktop solution, VDI. Remote desktop, if you have a physical desktop and you're working from home, you connect to that remote desktop. And there's virtual private network, okay? And I'm not going to get into the differences between all 4, but obviously if you're working remotely, you're using one or more of these techniques to get into the network. The point I wanted to make is that currently the cloud-based option, virtual desktop, remote, and the remote desktop already require multi-factor authentication. So if you're doing that, multi-factor authentication is nothing new to you, right? The big win is that beginning in 2021, we are, that multi-factor authentication is also going to be required for VPN access, right? So it's just a encrypted connection from your remote location into the Nisby network. It's like being here on the network, except you're working remotely, but every bit is secure. If you don't have an RSA token already, you'll want to go to mytoken.ny.gov to request one, and that URL will be presented again at the end of the presentation. I'm going to go through this, just skip over this one. This was actually just making the point that you don't even need to get into the Nisby system to do your much of your work. You have this available just in the cloud, right, through your browser. Coming back over here, just wanted to say very quickly, when you think of the phishing scams, right, which is typically an email that is sent to you pretending to be from a trusted source, asking for personal information, be suspicious, right? Because Psychiatry, for one, will never ask you for your password or personal information, and you should not be receiving emails from anywhere asking for your personal information or your credentials, right? And this is, you know, again, this is very actionable for you and I as users of a system to be suspicious of these things and be in the lookout for this so that we don't open up our system and infect our systems here at Nisby, right? So again, do not open links or sources you do not recognize, report incidents, right? And that's especially important because the sooner you report an incident to Psychiatry, the quicker we can act to contain it, right? Just to point out that the Nisby systems exist to support the mission, right? The very important mission of Nisby. There are, however, we need to just state that the prohibited uses of the Nisby systems include commercial use, unethical, illegal, or criminal purposes, distribution of obscene or harassing messages, unlicensed software, right? Use by non-Nisby affiliated users, and unauthorized remote access, right? And this completes the annual cybersecurity training. If you do, just for your information, if you do need any help with your passwords, there's self-service online. Again, the RSA token is, you can request one through mytoken.ny.gov. And for any additional services, you can come to this Psychiatry website, and we'll be very happy to assist you. And with that, I'm going to hand the podium over to Chief, who's going to speak of security.
When COVID-19 hit, you know, I was thinking, like, what am I going to talk about during the safety update? I mean, more unsafe than what was going on in the world with COVID-19. But then I thought, how can I have a safety update without talking about COVID-19? At all our entrances, we have our temperature screeners, at the parties, at the Cove. I mean, many of you use our temperature screeners daily. Some of you avoid the temperature screeners. You tiptoe, and when safety has their back turned, we see you sneaking around trying to avoid the temperature screeners. But we have cameras everywhere, so we know. So sometimes we've sent you an email as a friendly reminder, but these temperature screeners make you safer. They make the facilities safer, and it makes everyone feel safer, which is also important. So please use our temperature screeners as you enter the building and follow our COVID-19 protocols. Usually, Pete Reynolds talks about emergency management, but Pete Reynolds is no longer with us, so I'm going to talk about emergency management. And I was thinking, what would Pete Reynolds say right now if he was up here? He would say, "Are you ready for summer?" Because that's what Pete always talked about. In the wintertime, he'd say, "Are you ready for summer?" In the summertime, he'd say, "Are you ready for winter?" And at first, I thought that was a little strange. Then I said, you know what? What he was trying to prepare us to think ahead. This year when COVID-19 struck, I don't think anyone was properly prepared for COVID-19. But, we formed a COVID-19 task force and quickly began to plan. And everyone did a great job. Whether you worked remotely, whether you're here as essential staff, we all worked as the team, and it was very important. Those who reduced population density and worked remotely was equally as important as the people who stayed here essentially, because you all worked together to keep us safer. And everything had to be taken into account. Clinical services, how to maintain clinical services, and at first reduce our density and then ramp up our educational programs, how to keep continuity with our educational programs, and remote learning had to be utilized. Our research, how to first ramp down the research and then gradually ramp up the research, and at the same time keep our animals safe and keep our hazardous materials stored properly. So all that had to be taken into account. Communications was vital. Those who work remotely know that it was very essential to have our communications up to date, but also those who worked here. So IT played a great part in it. And of course, utilities. The building had to be kept running. In the summertime, we had to keep the place warm, keep the place cool. Wintertime, keep warm. And also our essential staff, the housekeepers, the safety officers, and all our essential staff had to be kept up and running. So that was very important. Our service net, which we already had set up, really became important because the service net, we have all our forms which could be accessed remotely, plus information. It was very important to keep our information up there, what was going on with COVID-19. So those of you who use the service net, who don't use the service net, please make yourself familiar with the service net. Our accident forms, every type of form that we really need is on the service net, so please use the service net. One thing that hasn't changed is that when we have emergencies, call 5555. I say this every year, and the reason I say it is because people do forget to call 5555 when there's an emergency. It's very important, whether it's a psychiatric emergency, medical emergency, any type of emergency, security-related, fire safety, call 5555. The above example is a radiation spill. We had a radiation spill recently. The person who spilled it didn't report it. They left after they spilled the radiation, so someone saw it, and they told an employee, and the employee ran up, told the safety desk and code, well, we have a radiation spill. What should have happened is to call 5555 so that we can contact Columbia University, who has a spill response team, and we can activate the system. I mean, things worked out. We were able to call the engineer, who were able to shut off elevator 9 to keep staff from becoming infected or becoming exposed, and radiation safety came and was able to clean the spill and properly keep everybody safe. And we made announcements overhead to keep people from going to the areas, but it's very important to call 5555 for all emergencies. Below is an example that no matter what occurs, people take advantage of situations. We have lower population density, staff density, which is great, makes us safer. But people took advantage of it. we had an empty lab, a relatively empty lab that was very rarely used. So one of the scientists came in one afternoon and noticed there was someone in the lab that they never saw before conducting an experiment. So they walked in and saw the person in the middle of the experiment and said, you know, who are you? And the person said, you know, introduced themselves. They said, well, who's your supervisor? The person couldn't give good answers, so they knew right away this person is an intruder. It's a small lab. They said, this person doesn't work here. So they said, what are you doing? The person said, I'm conducting an experiment. On what? They said, well, I'm looking for a cure for COVID-19. Don't tell anyone, it's a secret, but I'm working on a cure for COVID-19. So the person looked around the lab, the scientist, and saw celery everywhere. Celery on the lab bench, celery on the fume hood, celery all over the room. And on the blackboard was a formula involving celery. So the person said either this person loves celery or the person was really trying to conduct some kind of experiment for COVID-19. But either way, the person had no business in the lab and they were going to go try to get help. So the person, you know, the scientists said we're trying to get away from the person, while the person was distracted, busy working on the celery, and snuck out of the lab. So when the person snuck out one way, safety, the intruder snuck out and went out the other door. So we had the person on video where they were telling safety that person was sneaking out. We did a subsequent investigation and found that an employee, a rogue employee, let the person in so that they could conduct this experiment. Actually, this person had a history of unbalanced behavior and had to be let go because this was kind of emblematic of how this person behaves previously, so the person was let go. But, you know, one of the lessons learned, it was very important that call 555 because we don't know, maybe that person was unstable who was in the lab and that person could have been in danger. So they should have immediately left, call 555. That's why it's very important to use our services when you feel unsafe or you have some sort of emergency, call 5555. Well, that's it for my presentation. Just make sure you stay safe. Next up is Dr. Matthias Quick.
So hello everybody. Yes, this was a funny story. It was not so funny after we had to deal with the investigation of this incident. So as the chief introduced myself, I'm Matthias Quick. I'm director of lab safety. In this capacity, I also serve as the right to know officer and the chemical hygiene officer. So chief is the guy who's usually sending out his officers if there's a problem. I'm trying to convince you, act before. If there's a problem, if you see something, say something. If you have a question, reach out to me. Here's my email and my phone number. Just let me know, and I try to assist wherever I can. And as Ben Franklin said, failure to prepare is preparation for failure. So please make sure, consider all the different steps that help you to stay safe in this location, in this environment. Not just COVID, also lab safety, radiation safety, and general safety in terms of building access. So right to know is a law, and you have the right to know about the hazards you may be exposed to and how to protect against exposures. This looks like an old flyer here. In today's times, we have, as the chief and Alicia already mentioned, also I heard this before, there's the ServiceNet. So go to servicenet.nisby.org and you find all the information. For example, if you want to know about the right to know law, you click on the employee link and you will see a website that looks like this. So basically, all information is there, and you can see on the two spots here, which you may see here, the most important part is the safety data sheets, or the SDS. SDS is basically information about all chemicals that you have in the building. There are two links here. There's one for SDS organized by department, and this is basically what you see if you're working in engineering, housekeeping. Those are, I would consider, the general chemicals like cleaning detergents, for engineering like paint, and these things are listed here. And then also there's a link underneath that goes to ChemWatch. ChemWatch is a program that's basically provided through Columbia, H&S, and it lists all chemicals that potentially can purchase anywhere. We have currently about 12,000 chemicals in the institute, so if you need information on these, just click on this ChemWatch link and you will find all the information you need, particularly if you need medical assistance so you can provide this information to your first responder. As I mentioned, I'm the right to know officer, and if you ask me about any chemical, I'm required to provide a safety data sheet within 72 hours upon your request. However, as I mentioned, in times of internet, it more takes like 72 milliseconds to click on this link and have all information available. But anyways, any questions, please feel free to email me or call me. The next part is more like about the lab safety and hazard communication. So if you see any of those signs behind the door that you want to enter and you have no idea what this actually means, this tells you you need either stay away from this or you have to have the appropriate training. Because with the training, you familiarize yourself with the procedures that are basically happening behind this door and what kind of precautions you have to take. Training is provided through the RASCAL training module, through Columbia. Again, if you have any questions about what kind of training you should take, just let me know and I'll point you in this direction. Alicia mentioned already different waste types. So on the top right here is regulated medical waste or the red bag waste. Again, if a sample is not really exposed to any blood or blood cake, basically, as Alicia pointed out, it can go in regular waste unless, again, it's hazardous. There's also something that many people forget is universal waste. Batteries, computers is e-waste. Light bulbs, fluorescent light bulbs particularly, and with the new LED system used for bulbs, this is something you should be considerate. If you have a question, engineering can help, or again, send an email to me, I'll be happy to assist. If you took the training for basic lab safety training, you would know that this sign, the orange sign on the left, is the chemical hazardous waste. And this is the new waste label. If you find any blue labels in your lab, those are the old ones, and they do not have the check box marks on the bottom that are required by law now. Again, if you're using radioactivity in your lab, you would know how to fill out the radiation waste label, and we're going into details here. Hazard management. So if there's a spill, there are two types of spills. One is one that you can manage yourself. And again, if you're trained to interact with chemicals, you should know what kind of precautions you have to take. And if there's a spill, you know how to deal with this. If you are trained to interact with chemicals and you notice that this spill you cannot contain yourself or you need assistance, or if you're not trained and see something that seems very suspicious, it's time to follow the procedures listed under point B. So you should stop work. If you work with this, if you come by, just stay away as much as you can, but alert potentially exposed lab workers. The next point is, if you can, contain the spill, and also, if necessary, evacuate the area. But do not go away. As the chief just mentioned, it is important that you stay there. You are the one who saw the accident. If you see something, say something. Call 5555. And this triggers a sequence of events. Basically, Nisby Safety calls EH&S, calls the fire department, calls whoever is necessary to assist in this spill or any kind of accident, basically. Again, don't walk away. You know about the origin of the spill. So assist in the response and the cleanup. It doesn't mean you have to do it, but you can point people to do the proper thing and what you know about this incident. And then for medical attention, go to Occupational Health Services or the emergency room. And then, again, file an accident report. And where do we find an accident report? It's on the ServiceNet. And you can see on the, this is a section of the ServiceNet. And here is the employee and visitor accident report. So click on this one, and all information you have to provide is in very easy format to follow. It's permanent. There are updates to address many issues that are currently coming up. Just to go through. Some information about COVID. I just point you to the Nisby daily staff and student screening. If you come on site, please fill out these forms. They're really important. Just provide information where you're going. In times of COVID, you're alone in the lab. There's no buddy system. There's no second person around. Just make sure you are there and if you put in information, I see this kind of information and I know what kind of experiment you're conducting. If I see something suspicious, I would reach out to you and ask, what are you doing? Can we assist you? Is there another way to do the experiment? Those are the things we try to prevent, to prevent any accidents, basically. We just go through the whole thing, as I mentioned before. As Marshall mentioned, the controlled substances, just to make clear, this is only controlled substance in non-clinical research. It has nothing to do with clinical applications. This is not affected and has nothing to do with this. So most of those people who work with controlled substances have taken the training, which is in RASCAL TC for training course 0502. This is all wonderful. It's specific for Columbia. So what we are working on right now, we will work on a Nisby-specific training course on RASCAL. So this may be TC 0503. I don't want to promise anything, but this is coming very soon. And this is for non-clinical researchers working with controlled substances. All other non-clinical researchers at Nisby, they need to sign the attestation that they read and reviewed the Nisby controlled substance use in research training and policy. If you do not work with controlled substances, it's important that you know what to do in case if you see something that involves controlled substances. So any abuse, any mismanagement, you should be aware of in your environment and report this also up to your supervisor. And again, if you have questions, reach out to me. So usually we were here handing out those wonderful cards. Last year's were yellow. This year, you can choose the color yourself, so it depends on the paper you put in your printer. So as of this year, we have cards that you can for self-printing at home. There is a link on the ServiceNet, and all you have to do is go to ServiceNet, click on the quick links, and indicate that you want to print out your the safety cards. They go by Partis building and Corp Annex, and they go by the different other buildings. If you cannot print yourself from home or wherever you are, please reach out to staff development at nisby.columbia.edu or call Marshall's office, and they will be happy to assist you in all these endeavors. So since I'm the last one, I thank you for your attention, and I wish you a very happy, safe Thanksgiving, and I guess I will see you sometime next year. Maybe in the auditorium, maybe online, because this was very convenient. We do this once as opposed to 10 times. Okay, thank you.
Nice to meet you.
Likewise.
Nice to meet you. Is Cecil a C?
Cecil.
Cecil.
And I have to ask about the accent. What is your first language? I study languages, that's why I asked.
It's German.
Oh, no kidding.
But it's a mix, it's not straight German.
Yeah, I'm close to the French border, so it's...
It's Jim, my husband's accent is closer to yours than, but he has less of an accent, but his French, but it's not, but it's French, but his mother spoke French with a German accent. And German was his second language. So he sounds like a mild version of your accent.
No, it's essentially many people in America, it's German. It's French. Yeah, I'm very close.
I spent 10 years in France, which is, I also worked in Germany. But and that's why I was listening, and it was, I couldn't quite place it.
Do you know the nurse Pam Anna on the center? She's from Germany. She's a real straight, clean cut German accent. Yeah. We're in France, did you live?
Paris.
Which are in this month?